We'll do it. That's fabulous. I don't know if people in the back can see it, but the first speaker is Rosemary Underhill. Ms. Underhill, thank you very much for your comments.
Good morning. My name is Rosemary Underhill. I trained as a physician, a surgeon, and an obstetrician in London, England, and I shall present to this committee a request for some research in a neglected subgroup of patients with ME/CFS. The name benign myalgic encephalomyelitis, ME, was coined to describe a cluster outbreak of a disease in London, England in 1955. As a medical student at the time, I myself witnessed this cluster outbreak. The name chronic fatigue syndrome, CFS, was coined by the CDC to describe another cluster outbreak of a similar disease in the USA in 1984. Many cluster outbreaks of a similar disease have been described around the world at different times, but other names have been used. For example, non-paralytic polio in Los Angeles, Iceland disease in Iceland, Tapanui flu in New Zealand. Hyde found that 63 cluster outbreaks of a disease resembling ME and CFS were reported between 1934 and 1990, and 27 of them were in the US. On average, an outbreak occurred in the US about once every 2 years. Levine followed up patients from cluster outbreaks in the USA and New Zealand and found that many patients did not recover their health and their continuing symptoms fulfilled diagnostic criteria for CFS and/or ME. So patients whose illness started in cluster outbreaks make up a subgroup of patients with ME/CFS. Diseases occurring as cluster outbreaks separated in space and time are usually caused by one or more closely related infectious agents. Much research has been done in recent years looking for a possible causal agent for ME/CFS, but no known pathogen has been shown to be the cause. Research into causal pathogens has been hampered by several problems. Firstly, most research has been carried out on sporadic cases of the disease, and case definitions used for diagnosis demand that symptoms be present for 6 months. 6 months after illness onset, it may not be readily apparent whether any infectious agent could be primarily causal, the reactivation of a latent infection, a triggering agent activating a latent virus, or an opportunistic infection developing subsequent to the original illness. The importance of investigating patients in cluster outbreaks is that the pathogen is actively replicating, has an increased virulence. Patients can be diagnosed early on in the illness, and this provides a much better opportunity to find a causal pathogen, and also an opportunity to distinguish primary pathology from secondary pathology. Secondly, it's often stated that ME/CFS is not contagious. There is, however, much evidence that the disease can be communicable. Ramsey reported on 16 cluster outbreaks of ME/CFS and showed that affected patients have often been closely associated in families, communities, hospitals, or schools. In these outbreaks, the attack rate was between 3 and 7%, the incubation period was 4 to 10 days, and the disease tended to spread from person to person. In sporadic cases of ME/CFS is less contagious than in epidemics. I and my colleague did some research in family members of sporadic cases. We found 3.2% of patients' genetically unrelated spouses had an illness diagnosed as CFS, which was higher prevalence than the community prevalence, with a relative risk of 7.6 to 13.5. De Becker and his colleagues found that CFS followed a few days after blood transfusion in 6.5% of his patients. I request the CFSAC to recommend that the CDC's Epidemic Intelligence Service investigate this group of patients. I recommend the EIS and the ME/CFS research community seek out cluster outbreaks of every illness resembling ME/CFS and investigate both the patients and their close contacts in the hope of finding a causal pathogen. Thank you.
Thank you very much, Dr. Underhill. The next